Okay, it looks like it is 2:30, so we'll go ahead and get started today. Thank you everyone for joining us today. My name is Nikki Forbingor and I'll be moderating the briefing this afternoon. Please note that everyone should be muted unless they are speaking. We do have American Sign Language interpretation available today. If you search for interpreter stubs and hover over the three little dots in the window, you can lock it in place so that it's always visible as you're watching the briefing. So today we're going to hear from Health and Welfare Director Dave Jeppesen, our special guest, Dr. James Souza from the St. Luke's Health System, Public Health Administrator Elke Shaw-Tulloch, and State Epidemiologist Dr. Christine Hahn. With that, I will go ahead and turn it over to Director Jeppesen.
Well, thank you, Nikki. Appreciate that. And welcome everyone to our press briefing today. Just want to welcome Dr. Jim Souza, our very special guest from St. Luke's Health System. We appreciate him being here and we'll hear from him in just a minute. We're going to start by sharing our hospitalization chart, and I'll let Nikki bring that up for us here. This is the same chart that we've shared over the last couple of weeks now. And just as a reminder, this chart tracks the daily average census by week since of individuals on a ventilator that occurred back in December. These numbers continue to increase and we expect them to continue to increase. Nikki, thank you for sharing that chart for us. Despite the contingency actions taken by hospitals and the support provided by the state, crisis standards of care were activated statewide on Thursday, September 16th and remain in effect today. That means that the surge of COVID-19 patients has exceeded the healthcare resources available. I wanted to take a moment to clear up something about crisis standards of care implementation. It does not mean hospitals will automatically be applying universal do not resuscitate orders. The guidance for universal DNR is a potential strategy for hospitals to consider when both operating under crisis standards of care and triaging access to ventilators because the demand for ventilators exceeds supply. Further, if a universal DNR were to be enacted by a hospital, it would apply to hospitalized adult patients in the event of a cardiac arrest. It would not apply to pediatric patients. But I want to say again, activating crisis standards of care does not necessarily mean that hospitals will be applying a universal DNR. And that raises the question, what does crisis standards of care mean for you and I? And I'd like to share an infographic as I walk through this for just a minute. And thank you, Nikki, for bringing that up. Crisis standards of care means that it affects all of us, not just COVID patients. There are already many patients who have had to delay surgeries or other treatments. And if you end up in the hospital, you may receive care in a waiting room or a hallway. Each nurse and doctor will be taking care of more patients than usual. You may have to wait much longer than normal for care. You may even have to be transferred to a care facility that could be hours away. And tough decisions are made about how to allocate scarce medical resources. Finally, if you need emergency care, go to the emergency room. The hospital team will work hard to provide the best care possible. However, you should know your experience will very likely be different than usual. And Nikki, we can go ahead and stop sharing that chart now. Thank you. On Thursday last week, my family experienced what crisis standards of care means firsthand. My mom had a stroke Thursday morning, just a few hours after crisis standards of care was activated statewide. Not only was it stressful that my mom had a stroke, there was added worry about the availability of healthcare when she went to the ER. Things were different in the ER. There were other patients receiving care in the waiting room. My mom fell when she had her stroke, and there was a concern that she had broken bones. The x-rays were done in a non-traditional x-ray area with a longer wait than usual. Fortunately, she did not break any bones. Normally, a person in her condition would be held overnight for observation. Because of crisis standards of care, after she was stable, she was discharged later the same day from the ER. My family and I took over monitoring her at home, and she is recovering well. The ER team at St. Luke's was amazing. Despite the large patient load, they were caring, empathetic, and positive. We are so lucky to have such talented healthcare professionals in Idaho. And those same dedicated healthcare professionals across the state need our help. They need the unvaccinated to please consider choosing to get vaccinated. The vaccines work. They are safe and effective. And they need all of us to please wear a mask indoors and in crowded outdoor spaces. And with that, I'll hand it over to Dr. Souza.
Thank you, Director Jeppesen. I'd like to share an internal status update and then just a few words about the people who are sick in our facilities with COVID. If folks are interested in operational actions we're taking, I can potentially handle that in Q&A for more detail. For context, I think you all know St. Luke's oversees multiple hospital facilities across Southwest Idaho, extending from the Oregon border east to Twin Falls and then north up to Ketchum-Stanley and north up to McCall-Riggins. Bottom line, our inpatient facilities are progressively becoming COVID hospitals, and that's the same story for the rest of the state. Some detail on that. We've gone from 33 COVID hospitalizations across our system in July to 289 today. That's at St. Luke's. COVID previously accounted for about 8% of our adult hospitalizations, and today it accounts for 67% with this single diagnosis. That's an unprecedented event in modern medicine. In our ICUs, the story is a bit worse. In July, we had 8 COVID ICU admissions across our facilities, and that accounted for 17% of our adult ICU hospitalizations. Today, we have 51 COVID ICU patients, and they account for 70% of our ICU patients. A few words now on what we're seeing with the patients that is significantly different from the December surge. And I wanted to highlight 5 things. First, they're younger. The age range of our adult patients today is 20 years to 85 years with a 2-week running average of 58 years. That's down from 72 years in the December surge. Of the 51 people with COVID in the ICU today, 36 are under the age of 55 and 13 are under the age of 40. We think this is probably in part due to maybe increased virulence of this Delta variant, but we mostly believe this is due to the higher rate of non-vaccination in this younger population. Which brings me to the second change in the pattern we're seeing. The patients are overwhelmingly unvaccinated. Now, this is similar to the December surge because we had no vaccine at that time. But what's new since the introduction of the vaccines is that we are mostly not seeing an entire segment of the population in our hospitals. The vaccinated, we're not seeing them. And we almost never see those individuals in our intensive care units. For some specifics, of our 289 hospitalized patients, 90% are unvaccinated. And of our ICU patients, 98% are unvaccinated. The ICU patients we do have who have been vaccinated are patients who are actively being treated for cancer with bone marrow toxic chemotherapy and patients with organ transplant on immunosuppression. The third difference, these patients are more sick. We're seeing increasing rates of mechanical ventilation, and that's at least in part because this younger cohort of patients tends to choose more aggressive care when they're hospitalized. If we're honest about it, 40-year-olds have not contemplated death before. For more specifics, amongst our ICU patients, of the 51 critically ill COVID adults, almost all of them are intubated and mechanically ventilated, And today we have a total of 64 ventilators running versus a typical value in a flu season for us in our health system of about 23. We're also seeing increasing rates of acute kidney injury, and we're continuing to see what we believe is an increasing rate of clotting events. And we've known about the association of COVID with clotting since the beginning of the pandemic, but we're seeing this now in younger patients: DVT, clots in the legs, clots in the lungs, pulmonary embolism, arterial clots in the heart attack, and in the brain, stroke. Fourth difference: these patients' length of stay in the ICU, if they survive, is longer versus what we saw in December. At that time, we had an average ICU length of stay of 6 days, and we're now sitting at about 8. And remember, this is average. The many patients who die often do so relatively early after ICU transfer, and on the other hand, we've got many patients who occupy an ICU room for more than 3 weeks. The final and really important difference is that these patients are dying more frequently. When compared with our winter surge, when our ICU mortality was around 28%, we're now seeing an ICU mortality rate of about 43%. We've had 80 deaths from COVID in our health system since the beginning of September. That's 4 every day the sun comes up. 35 of those deaths occurred in the past week. Among the 80 deaths so far in September, 23 of those were in people under 60, 12 in people under 50, 6 in people under 40, and 3 of these occurred this month so far in people less than 30 years. In a really morbid exercise, just in the month of September, if you look at the ages of the people we have lost, and you apply to them average lifespans, we have lost more than 1,100 life years. A life year is one person's experienced year of life. Can you imagine that? And for the people who say we all die sometime, yes, we do. But these people didn't need to die now, and they didn't need to die like this. And I'd like you to think about those 1,000 plus lost years of life in the past 3 weeks, just at St. Luke's. Can you imagine all of the life and experiences contained within those 1,000 plus years? We shouldn't trivialize that. These people deserve better. The last thing I'd like to comment on is a bit of a false narrative of sort of binary outcomes, that you either live or you die from COVID. The true fact, for those who practice with these patients, is that for those who don't end up in the ICU, there are a substantial number who are ultimately going to make a full recovery, and that is terrific. But for 30%, they won't. And they're going to have lingering symptoms. They're going to need healthcare resources, and we don't know for how long. For those who go to the ICU and survive, they will be terribly disabled for at least a short period of time. I mean, I'm talking months. And sometimes that will be permanent. You cannot spend 4 weeks on mechanical ventilation, paralyzed and sedated, and then stand up and walk away. The lost wages, the increased healthcare costs for these individuals long into the future need to be part of the total accounting for the cost of our experiment in naturally acquired immunity. Director, that was sort of the status update in terms of the patients. And again, I'd be happy to stand for questions on operational levers that we're pulling.
Great, thank you, Dr. Souza. We'll hear from Elke and Dr. Hahn, then we'll circle back around to questions.
Yeah, thank you, Director, and thank you, Dr. Souza, for some very sobering remarks, and for sure. And Director, thank you very much for sharing your personal story. So for what I would like to update you on is some of the progress that we're making given this crisis in our healthcare system right now, and things that we're continuing to do to support our healthcare partners. We've been talking about it for several weeks. We continue to provide daily logistics and resource support to our healthcare system, as well as funding and staffing support. As a reminder from last week, I stated that hospitals, as well as freestanding primary care and urgent care facilities, have been eligible for funding. We made $4 million available for hospitals and $1 million available for primary and urgent care. The demand for those resources has exceeded the amount of funding that we had available. And I am happy to report, as you probably saw in the governor's press release earlier today, that we have an additional amount of money that's available. We have an additional $3 million that's been that we have available. In addition, we also have $3.5 million that's been made available for skilled nursing facilities, bringing it to a total of $8.5 million in the course of the last few months to support long-term care facilities, specifically skilled nursing facilities, to help take patients that are discharged from the hospitals. So we're providing funding support to increase the capacity at the hospitals, support our long-term care facilities to take patients out of the hospitals to free up space, as well as providing funding support to our primary and urgent care facilities to keep people from getting into the hospitals. Additionally, regarding staffing, we continue to partner with our friends at the Idaho Office of Emergency Management, and we continue to review applications that come in and allocate staffing resources. To date, in addition to the 20 Department of Defense clinical staff that were deployed to Kootenai Health, we have other staffing requests that we've filled through the request for assistance process. 257 of 555 requested personnel have been assigned to 15 RFAs, or those requests for assistance, across the whole state. These are being fulfilled through the federal GSA contract as well as the Idaho National Guard. Specifically, we've filled 216 of the 337 requested clinical positions at the following locations: Kootenai Health, St. Alphonsus Regional Medical Center, St. Luke's Health System, Steele Memorial, Clearwater Valley Hospital, St. Mary's, Shoshone Medical Center, Weiser Memorial, Cascadia of Nampa, and Orchards of Cascadia. We've also filled 41 of the 218 requested non-clinical positions at Kootenai, St. Alphonsus, St. Luke's, Clearwater Valley Hospital, St. Mary's, Desert Sage, West Valley, Salzer Health, Primary Health, Southwestern District Public Health, Valor Health, Shoshone Medical Center, and Weiser Memorial. Requests for assistance are coming in continuously, and we review those requests on a weekly basis, making those allocations. As you noted, probably not all of the requests are being fulfilled at this point in time. Many times we have to go back to the requesters to get additional information to make sure that we're putting the right resources in the right locations. But we are continuing to get those reviewed quickly and out as quickly as possible. You heard some compelling information, and I want to continue to strongly emphasize that everyone has a role to play and to support our healthcare capacity. You heard throughout the course of last week, this week, and today some very compelling information about the impact of COVID and the devastation it brings to families, our communities, and our healthcare partners. We ask you to do a few things, and we say this every week. Get vaccinated. You're 6 times more likely to be hospitalized if you are unvaccinated. And discussed earlier, Dr. Souza put it very well, the vast majority of people in the hospital right now with COVID-19 are unvaccinated. Wear your masks indoors and in crowded outdoor locations. Get tested and stay home if you're sick. You can find testing locations at gettestedcovid19.org. You can call the Idaho Care Line to order free at-home saliva-based PCR testing. We're in the process of even making more tests available for free to the public. We're trying our best to eliminate every barrier to be able to do this. Know that an influx of testing demand and cases is increasing the turnaround times for testing, so plan now for those delays. Do not use the emergency department as your place to get asymptomatic COVID testing for work, concerts, travel, things like that. You've heard the stresses that they're under. It makes sense. That said, if you're symptomatic and need help, of course, we encourage you to visit a healthcare provider or the emergency department if the issue is warranted. And last, of course, be careful. We've said this before. Take care of yourselves. Avoid getting ill from any cause and avoid activities that create the need to go to the emergency department. To wrap up today, my last update is about school testing and support for schools. 47 schools or school districts have indicated an interest in the $30 million that we made available for K-12 schools to address COVID testing. Funding is in progress for 11 of those organizations. We're providing subgrants to those awardees. Funding was declined by 5 of those organizations because they just want access to the testing kits. So to remedy that, we have a new state level school-specific contract with Vault that's pending, in addition to those that we're making available to the public through our 211 care line. We want to make sure that those supply kits for schools are available in Idaho. Because of demand for more timely results than the Vault can provide through that PCR testing, we're also exploring contracts with 3 manufacturers for rapid test solutions. And so that is the conclusion of my update. I'm going to turn it over to Dr. Hahn for her remarks, and then we'll open up for comments after that.
Thank you, Elke. Can you hear me okay?
Yes, we can, Chris.
Okay, thank you. Yeah, thank you so much. I just had 2 quick things I wanted to cover that haven't already been addressed in detail. One is monoclonal antibody use. As you recall, the governor announced August 26th support to increase the use of monoclonal antibodies in Idaho for treatment of patients with COVID-related illness, especially those at high risk. We've already announced, but I just wanted to give you an update up north. Things have been going very well. Heritage Health has taken the lead and has begun operations in the Kootenai County Fairgrounds. They let us know this morning they have treated 90 patients in the first 3 days of their operations, including 30 assisted living facility residents that they're also reaching out to. So we're very pleased with how things are going there, and they continue to work hard to try to offer this treatment for people at high risk of being hospitalized. In Eastern Idaho, we have secured a relationship with Mountain View Hospital in Idaho Falls. They have already been offering monoclonal antibody treatment, but they will be expanding under this funding to add increased hours in Idaho Falls. They've already done that, and they will also be adding sites in Blackfoot and hopefully next Pocatello. So they are already up and running and have expanded their work already. I want to remind you also that there are currently 32 Idaho providers around the state. These aren't the only places for patients to go get treatment. And we have seen quite an increase in orders around the state for this treatment. However, that brings me to my point and why I'm talking about this today. I have two main concerns I want to make sure people are aware of. One is we've been given informal word, not a specific number, but there will be reductions in the amount of monoclonal antibody allocated to the states because of a shortage due to the manufacturers had started to ramp down production when it appeared that the pandemic was on the wane. More recently, the federal government has purchased more antibody, and that is going to be coming, but at least for a short period of time, we're expecting a decrease in the amount that we'll be receiving into Idaho. And so we want to use this opportunity to emphasize to Idahoans 2 things. One is this is not a replacement for a vaccine. It is not a wise strategy to hold off on getting vaccinated thinking I'll just go ahead and get that antibody if I do get sick. 2 reasons for that. One is the antibodies don't give you long-lasting protection. They will help. They should help keep you out of the hospital, keep you from getting sick. People report feeling much better after the treatment pretty quickly. But the antibodies, once they're gone, they're gone. It doesn't teach your body to make antibodies, and you are just as vulnerable to COVID as you were before. So please do not use this as a substitute for vaccination. The other reason that that's super important is if there's a shortage and we already know there's not enough for everyone, there's not enough monoclonal antibody for everybody to get that treatment, you may not be able to get monoclonal antibody should you get COVID. So you don't want to rely on that strategy. The second thing I want to talk about briefly is booster shots. Quite a bit of news that I'm sure many of you have been following. We've been watching this very closely in Idaho. The FDA's advisory committee met last Friday, and much to, I think, the surprise of many people, did not recommend boosters for everyone. When I say recommend, they recommend to the FDA what should be authorized for use. And they recommended to the FDA people 65 and older, healthcare workers, and then people in certain high-risk occupations other high-risk occupations that might put them at increased risk. What that really means is going to be fleshed out by the CDC's advisory committee, hopefully this week. They're starting to meet tomorrow. They can't finalize their recommendations until the FDA issues that authorization, which as of last time I checked this morning had not yet happened, but it's supposed to happen today, hopefully, or tomorrow. So that is an ongoing process. We're watching that very closely because, of course, that impacts planning here in Idaho. We are quite certain that seniors 65 and above ultimately will be authorized and recommended to receive the vaccine. So our vaccine program, and there are folks from the program on the call. We are planning on being ready to start vaccinating seniors and making sure seniors know where to go, whether it's their local pharmacy or if they live in a long-term care facility, that facility is ready to start offering boosters for seniors. We have polled the hospitals, and I know many of them will be offering boosters to their staff as soon as that is authorized and recommended. So a lot happening there, and we are staying abreast and making sure that we will be ready once those final recommendations come out. So that's all I had to say. Thank you.
All right, thank you, Dr. Hahn. So we're going to now go ahead and take questions from the media participants. Most of you already know these instructions, but please raise your hand in WebEx or type your question into the chat area. When I say your name, you can unmute yourself and announce your name and media outlet before asking your question. And please remember to clear your hand when you're done. If you do want to ask a second question, clear your hand and then raise it again so that everybody gets an equal chance here. Our first question today is going to come from Audrey Dutton.
Hi, Audrey Dutton from the Idaho Capital Sun. This question is for Dr. Souza. So folks who are vaccinated and who are wearing masks, what can they do still to help the situation? You know, we've got healthcare workers who are burned out. What can the public that's already on board with COVID prevention do to help the situation right now?
Thank you. I really appreciate that question. Thank a healthcare worker, and please do it today. The physical fatigue and the compassion fatigue these workers are experiencing is real. They're digging deep to continue to provide great care to people who need their help, and they're serving all of us. So when I say thank them, I'd ask you to do that with words and to do it with actions. So, you know, if you know a healthcare worker, call them or text them today, please. If you don't know one, that's okay. Write a generic card and send it to a healthcare provider. Any healthcare provider. Our healthcare workers are putting themselves ahead of others in big and small ways right now. And the good wishes from the beginning of the pandemic feel like they've sort of all but dried up. The second thing I'd ask is to thank them with your actions. You already heard from Elke. I mean, this is a time when we all actually need to go back to our masks again for a little while. And I've been out there in public. I know what it's like. Be brave. Be the one who's willing to stand out in the crowd and set the example for how we get through this together. And if you need, you know, an excuse at the ready, just be ready to say that you know healthcare workers and they need our support right now. That's all you need to say. That'll defuse anybody. If you're not vaccinated, I can't miss this opportunity to make an appointment today, because if you do, that's a really important action that supports healthcare workers. And then if you are vaccinated, and that's the question you asked, the other action that you could take besides modeling the sort of good behavior we need to take care of one another right now is do what's really hard and commit to have a real conversation with someone you know and love who's not yet vaccinated. Not a boulder throwing conversation, but one where you approach it with curiosity and listening, and share some of the data you heard today. Thanks for that question.
Thanks, Dr. Souza. Our next question is going to come from Melissa Davlin.
Thanks, Nikki. Melissa Davlin with Idaho Public Television. This is either for Dr. Hahn or Director Jeppesen. Director Jeppesen, you said last week that there's no real peak in sight right now. And with that in mind, knowing that monoclonal antibody treatments are in short supply, or at least shorter supply than we need as a state, have there been any discussions about how to dole out those treatments, as more and more patients will likely be needing those in coming weeks? I know at least one state has said that those treatments need to be reserved for the unvaccinated as opposed to the vaccinated. Any discussions like that here?
Process. This all happened last week, that we were thrown back into the allocation process. So right now we're just trying to get those orders out so that there's no delay in people getting, providers getting the antibodies. However, we have started to look at the National Institutes of Health treatment guidelines, for example, and other resources do have recommendations. For example, although some of these products are authorized for post-exposure prophylaxis, one recommendation is to focus it on people who are ill, not just have they been exposed. And we've already emphasized that with our treatment facilities that we are funding, that is the priority. Next steps could include looking at the list of people who are eligible and prioritizing them. We have not done that yet, but as Elke mentioned, we have started to think about that already, because we have not seen a reduction yet in our allocation. We just got our new allocation today, and it is actually the same, holding steady as last week. But we do need to have those conversations now. So if we do see a cut, we are ready to prioritize.
All right, thank you, Dr. Hahn.
Dr. Souza, did you want to add anything from in the clinic?
Yeah, I can't miss the opportunity to, I'm not the immune expert here. So for details on vaccine immunity versus natural immunity versus acquired immunity through, antibody infusions, I would definitely defer to Dr. Hahn. But I do want to make a comment, that I've seen that debate out there, and I frankly, I've been in that debate with some individuals, and it's a really interesting intellectual exercise. And my belief is that one day we will have a more definitive answer than perhaps we do now about which type of immunity gives the best protection and for the longest period of time. But I guess the point I want to make is I think the conversation misses the point, and frankly can be a bit of a distraction. At least right now, whether or not one kind is a little better than another, vaccine, natural, acquired, I think that is all way less important than the cost of getting the immunity. Within the past 2 weeks, I read something from the Kaiser Family Foundation that in the past 3 months alone, the United States has spent almost $6 billion saving the lives of unvaccinated COVID patients. Now, first comment about that, that is not an unworthy expenditure. I'm glad that we are trying to save everyone's life. But the point is that the cost of our natural immunity experiment we're carrying out right now, the cost of that is what I shared in my report out, plus $6 billion, which, by the way, does not account, I believe, for the surge in antibody treatments that we're now seeing. And it doesn't account for the lost wages and the lost productivity and the lost school time for kids and the long-term disability and the cost of long-term COVID. So when comparing and contrasting the different ways of getting immunity, and like getting an antibody infusion versus getting a vaccine where your own body would naturally produce a similar response, and by the way, you can get that vaccine for free, I think the cost benefit shakes out pretty clearly.
Thank you.
Thanks, Dr. Souza. Our next question is going to come from Jack Schemmel.
This question is most likely for Dr. Souza. Well, it is for Dr. Souza. I'm with KMBT in Twin Falls. Speaking towards St. Luke's in the Magic Valley, I know last week during the hospital meeting, you guys said 3 to 4 extra rooms.
Situation, you guys, is, I mean, planning for this disaster is not like, it's not like traditional disaster planning, like you might plan for a natural disaster, a hurricane, or a terrorist attack, where your planning is, well, we might go from a 50% capacity to 0 like that. Instead, we've progressively eroded our capacity, so we're at less than 5% at any given moment. You know, and sometimes less than 1 or 2% at any given moment. So this past weekend in Twin Falls, actually, we had 5 patients deteriorating over a relatively short period of time. It was over about 6 hours or so on our medical floors. We had no intensive care unit beds available. And you know, in that moment, we came close to an allocation type decision. Now, we were able to avert that because our partners in Eastern Idaho took 2 of those patients. Our partners at St. Alphonsus took a patient, and we were able to make capacity in Boise, in part due to COVID deaths. So there's not a lot of room at the top of the tank. And that event, by the way, where 5 patients are deteriorating over a period of 6 hours on a Saturday on hospital floors inside of a hospital, that's as common as the sun coming up in healthcare. I wouldn't have enough fingers and toes to count the number of times that working as an intensivist, I experienced that same phenomenon in you name the hospital. This happens every day, and yet when it happened on Saturday, we were really pressed to find a solution, and thank God we did.
All right, thank you, Dr. Souza. Our next question is going to come from Kyle Fonensteel.
Thanks. This is Kyle Fonensteel with the Post-Register. A 2-part question. Which hospitals have used crisis standards of care, and how will the public know when hospitals are in crisis standards of care?
Great, thank you, Kyle. I'm going to ask the director if he wants to take that.
Yeah, thank you, Kyle. That's a great question. So as you know, we've currently activated crisis standards of care statewide. That does not mean every hospital is currently operating their crisis standards of care plan. And we actually, we're not formally polling hospitals to know which ones are in and out. And the main reason for that, as Dr. Souza just described, and is particularly in the critical access hospitals, is it can change by the hour. So you could be in crisis standards of care for a couple of hours, then you could be out for a couple of hours, and you could be in for 12 hours, and you could be out for 24 hours. And so we were not actively trying to track which hospitals are formally in crisis standards of care or not. Some hospital entities have made some decisions to publicly share when they have entered into crisis standards of care, and we support that. But we're leaving those announcements and those determinations up to the hospitals. The same way we have all along, which is we were waiting for the hospitals, who are the experts in what they run, to let us know when we at the state level reach that point. And so we don't actually have an active list for tracking of who's in and out, and will depend on the hospitals if they want to share if that beats into their plans.
Okay, thanks, Director Jeppesen. Our next question is going to come from Rebecca Boone.
Thank you, Rebecca Boone, Associated Press. A week or maybe 2 weeks ago, you mentioned that you'd be trying to reach out to the VA to see if they would be able to take overflow of COVID patients or other patients. Have you gotten word back on that yet?
Yes, and yes is the answer to that. So they are able to take citizens, not citizens, civilians is the word I'm looking for. The VA has been able to take civilian patients on behalf of other hospitals, and I know that has been utilized. I've had patients transfer there, and there's also been a request that the Spokane VA be able to take civilian patients, and they do as well as part of our transfer pattern, and also supporting, of course, Washington State, since they are in Washington State.
All right, thanks, Elke. Our next question is going to come from Ian Stevenson.
Thanks, this is Ian with the Idaho Statesman. I have a question for Dr. Souza. In your comments just a moment ago, you were talking about one of your facilities being close to potentially having to allocate care, but not being quite there yet. And last week in your comments with other hospital administrators, you were talking about some of the contingency measures and sort of unusual methods that you're having to use to treat patients at your facilities. And Dr. Jeppesen was just talking about how crisis standards of care can be sort of in flux as things are moving, but I was hoping to get your perspective sort of on, in terms of the difference between operating under contingency standards like early last week and now. Are there some differences that, aside from having to allocate care, some differences in treatment that patients can expect or that you're seeing when people come into your hospitals, given the crisis standards?
Yeah, I mean, first of all, we feel that there has been a change in the usual standard of care that we provide, and then therefore, based upon the state definitions, we are operating in crisis standards. I think Director Jeppesen did a really nice job of summarizing that up top, and he actually used his own mother's experience. I mean, she did not get the same. We're happy that she's doing okay, but she did not get the same sort of care, the same timeliness of care as she would otherwise have received. And in fact, she also generally would have been admitted for observation, and that did not occur. So to be clear, for St. Luke's, we moved across the line right around the time that we made the appeal for crisis standards of care and had that request honored. So we're not providing the same level of care. I mean, if you were to ask some of the breast cancer patients whose surgeries are now postponed with an indefinite time period to restart, you would hear from them, yeah, I'm not getting the same quality of care I used to get. You would hear the same thing from our respiratory therapists, if you ask them about, doing relatively high levels of non-invasive ventilation on medical surgical sites of care instead of intensive care units, because that's the best we can do right now. We have, so to describe it, it's like everybody is going with a little bit less. We're still not at a point, however, where we feel like we need to make a decision up front about allocating or not allocating a resource to an individual patient, or on the back end, deallocating a resource that a patient has had, like a ventilator in an ICU room, in order to give it to another patient. We have not reached that point, but as I think I and we and so many others have said in the past week, if the surge continues to increase, we will reach those points. And perhaps to put an emphasis on that, we stood up the teams this week to be ready to support our frontline clinicians in these very morally challenging decisions that they might find themselves needing to make. Hope that answers your question.
Thanks, Dr. Souza. Okay, our next question is going to come from David Mack.
Hi there, David Mack with BuzzFeed. I'm just wondering, I guess, first question for Dr. Jeppesen. It doesn't sound like it, and I am sensitive to HIPAA requirements here, but are you aware of any deaths so far linked to the implementation of crisis care standards? And if not, will you be surprised if and when that starts happening?
Director, do you want to take that, and maybe Dr. Souza can follow on? Did lose Director Jeppesen? Director, if you're speaking.
I got to get off the mute. Thank you, David, for that excellent question. And I'll start and hand it over to Dr. Souza. I think Dr. Souza described it well as to where we are in the process, which is the level of care is less than it was. We certainly, and the other thing I'll just say is we certainly see the number of COVID deaths accelerating at a frightening pace as a result of the progression of the disease. But I'll let Dr. Souza speak to if there's any direct correlation of moving into the crisis standards of care and affecting the number of deaths.
Yeah, thanks for the question. I do not know the names of any such people yet, but I do believe we will know their names. You can't take healthcare systems that are used to providing care that seeks to be flawless, right? Flawless in all elements, consistently delivered, the entire checklist run. I said in a conversation last week that the state of Idaho is blessed to have multiple award-winning healthcare systems, and two of us in the Treasure Valley here, St. Alphonsus Health System and St. Luke's Health System, are IBM Watson top 15 in the country award-winning facilities, right? Well, how you get there is by designing your care not for the moment, but the way I described this was just in case. So we've got backups to our backups just in case we need them, right? We care for patients who need non-invasive ventilation historically in an intensive care unit just in case they need a higher level of respiratory therapy support, because guess what? You can vomit, aspirate, and get in trouble wearing one of those masks. We have certain nursing staffing ratios just in case a patient needs that extra attention, and on and on and on with these just in case examples. Well, now just in case is really no longer in play, and we're bringing everything to bear that we can to meet the immediate needs as best we can right now. So I think for any of us to think that there won't be consequences from that, I just think would be naive. That quality of care has already changed and will continue to erode if the size of the spike and this surge continues.
All right, thank you. Our next question is going to come from Andy Sullivan.
Hi, this is a question for Ms. Shaw-Tulloch. You mentioned several school systems have applied for testing money. How long until they get that money, and how long until that will enable them to have a testing system set up within the schools? And then separately, most schools in Idaho don't seem to have mask mandates. Is that counterproductive to be taking money for testing when you're not doing this very basic thing to stop the spread?
Great, thank you for the question. And I'm going to have Dr. Turner, who's on the call, also help support this answer. So as I mentioned, we have funding in progress for 11 organizations right now. So those are sub-grants that we provide to the schools. We made that process really simple and easy to do, just a quick kind of registration form they fill out. So those sub-grants are in the process of getting out the door, and as soon as they are signed by both parties, then money can flow, of course. So those don't take very long once they get to a certain point, and if they're in process, I would say within a matter of a week or so, they'll be out the door. I'll have Kathy verify that. And then, but of course, as I mentioned in my opening remarks, we also have schools that just want the test kits themselves. So we're trying to facilitate that process, make it super easy for them just to be able to have testing kits available to them, and utilize that process as opposed to more comprehensive support that they want to give. So I'll have Kathy address that. And then regarding the mask mandates, some schools have in play. We want to support schools to do anything they can to reduce COVID transmissions in their environments. And of course, we talked about this before. We do support the use of masks in schools. We think they're effective ways and effective tools to mitigate the spread. So of course, we would like to see more and more schools implementing mask usage. And with that, I'm going to turn it over to Dr. Turner and see if she has anything else to add for the timing of the grants.
Thank you.
Thanks, Elke. Andy, to answer your question about how quick the money will get to the schools, first of all, we do have 11 in process, different places in that process, but for those who the process started pretty quickly early on, it could be a matter of days before that mechanism is in place for them to get the money flowing to them. I do want to just make it clear that just because schools don't have this particular funding doesn't mean they don't have funding available to them to implement testing programs. And for the most part, the schools and school districts that are taking advantage of this funding are using it to enhance ongoing testing programs that are already in place. So I want to make it clear that just because this funding hasn't gone out the door doesn't mean that testing programs are not in place in Idaho schools.
Do you have an idea of how many schools have testing programs in place in one form or another?
Andy, I don't have that because I do not have the perspective on every school in Idaho. I can tell you that 47, is that right, Elke? Is that the number I gave you?
Yes, 47 schools.
47 schools or school districts have indicated interest in the funding. And I think after we get off the call, I can maybe follow up with the number of them that have indicated they already have a testing program in place.
Thank you.
All right, thank you, everyone. It looks like Audrey Dutton will have the next question.
Yeah, this question is for Dr. Souza again. How are patients and family members reacting to the crisis standards of care? Like when they're getting the not normal standard of care, how are they reacting to that?
Well, first of all, I think patients, who have needed our care frequently and been in quite a bit. They may not detect major changes. As someone, though, who's responsible for the care delivered and accountable for it, my previous comments on the standards of care and the quality of care changing and eroding, they stand. A patient isn't going to know that, behind the scenes, all the systems and processes in place to make sure that first and foremost, the care provided is safe and then is highly consistent and of high quality. I've generally been, what I've heard is that our patients are generally incredibly appreciative of the care that they're getting. Hope I answered your question.
Did, thank you.
Okay, our next question is going to come from David Mack.
Hi, this is also for Dr. Souza, and it's following on from something you said about feeling as if the goodwill from the public has kind of all but dried up. It seemed to mirror some comments made from Dr. Krell in Idaho Falls, the gentleman with that viral whiteboard message who was talking about having a commonality that the public is no longer our allies and feeling that there's some patients with hostility that his staff are interacting with. And I'm aware that your facility in McCall had a swastika drawn on it over the weekend, and it sounds like that's a sentiment that you're also experiencing. And I'm wondering what you think has changed in the public and what's brought that about.
Thank you for that question. I think what's changed is that so many people have been misled. Our workers right now are, in addition to experiencing a lot of physical fatigue, there is so much compassion fatigue, and a significant amount of that is driven by frustration, and I'm actually also going to name anger. And I think if we name it, then we can figure out a better way to direct it. My advice to our health system, and my advice to all healthcare workers, and my advice to all people of goodwill who want to see this thing put behind us, is to direct your frustration and your anger where it's more healthy, and that is at the people who are sowing the misinformation. Please remember that when the people who are being misinformed get this infection and they take the false treatments offered by these doctors and then they get really sick, who do they come to? They don't go to them, they come to us, because they know that regardless of their beliefs or their actions, we're going to do our very best to care for them and to try to save them, because that is who we are and that is what we do, and it's the beating heart of healthcare in this country. So, when the chips are down, they know who they can trust. I do just wish more people knew that. I wish more people would and could listen before the chips are down. And until then, the focus of my frustration, and where I'd ask people to direct their frustration and their energy, is at those purveyors of false and misleading information who are leading so many astray right now.
Thanks, Dr. Souza. Our next question is going to come from Vinny Del Giudice.
Thank you. Vinny Del Giudice at Bloomberg News in Denver. A question about the state's vaccine inventory. With vaccination rates so low, have you been experiencing vials expiring, or have you been shipping them out to other states where there's a need? Thank you very much.
All right, thanks, Vinny, for the question. And we have Sarah Leeds on the phone to give us an update on that.
Thanks. Elke, can you hear me?
Yes, ma'am.
Great, thanks. we have had some vaccine expire this month, and but in terms of the inventory, we have multiple weeks of inventory, so we are prepared for booster doses, and there's no concern about access for whatever the FDA may authorize or the ACIP may recommend. The state has adequate inventory to support that demand, and we are ready to order more as needed. But there has been some inventory loss due to expiration recently.
Has it been more than you would anticipate or more than other states are reporting, being you've had such a problem getting people to get vaccinated?
Vinny, I think what I probably need to do is follow up with you to give you some exact numbers. I don't have them at my fingertips right now, and need to talk to some of my staff. But we have had a slightly higher wastage number than the state, and part of the explanation for that is that there are multiple doses in a vial, and across the board we have been encouraging providers to puncture that vial, administer a dose when someone chooses to get vaccinated. And so if there's one dose used in a vial and we have to waste 13, we don't like that, but that's what we need to do. That's where we are in this pandemic response to get people vaccinated. And so Idaho's wastage rate is slightly higher than the rest of the country, but on average, it's not of concern. We talk to CDC weekly about it. We talk about wastage, and they know that we're doing everything, and our providers are doing everything they can to not waste vaccine. And we have been working to move vaccine around to where it's needed when it is close to expiring. But I will work with staff to get you exact numbers to the exact we can, and I'll work with Nikki to get you those.
Thank you very much. Have a good evening.
Welcome.
Thanks, Sarah. Okay, we have 3 more questions. I'll just, in order, they're going to be Kevin Richard, Ian Stevenson, and Melissa Davlin, since we are at the end of our time, but we'll get through those last 3 questions. So Kevin, you're up.
Thank you. This is Kevin Richard from Idaho Education News, and I think this one will be for Elke. Can you walk us through a little bit more about the contract for testing supplies for schools and how that would work? What are the mechanics of this? And is it also going to be on a voluntary basis as the current program is? Or are you trying to get more reach in the schools than the 47 schools that have expressed interest in the testing? Can you just walk us through that a little bit more?
Yeah, thanks, Kevin. I'm actually going to have Dr. Turner do it, as the contracts are managed out of her bureau in our division. So Kathy, do you mind filling in the details?
Yeah, it's a great question, Kevin. So let me walk you through the process. After a school or school district registers with the state to indicate their interest, we actually have a one-on-one follow-up call with their contact person, and those conversations are taking anywhere between an hour to an hour and a half, because I think we can all agree that schools are not necessarily experts in testing, and so part of it is talking through what they want, what they don't want, what they envision in the future, what do they want short-term versus long-term. And so after those conversations are over, we construct what we call a sub-grant, which is basically a way of us sub-granting money to another entity. And we have both parties sign it with the agreement to send us aggregated numbers of the testing volume. And then that is implemented, and then the school has access to the level of funding that they want to have for whatever program they have chosen. Now, some schools may want a, all bells and whistles program. Others might want a very, very simple program where they're, we're paying for a staff person that oversees the dissemination of test kits or something like that. So it's not one size fits all. I think it's going to look different in every location. But that kind of gives you the process of how we're walking through this and making sure that we're giving the schools exactly what they need to implement what they need.
And just to be sure, the contract for the vault testing, that's voluntary as well? The schools don't have to do it?
Yeah, so the contract with Vault is at the state level. We are just contracting with Vault. We're paying for those kits to be available to schools who want them. Is that helpful?
Yes, thank you.
Okay, thank you. We'll move on to our next question, which is going to come from Ian Stevenson.
Thanks. I have a question probably for Dr. Turner. I wondered if you all have an update on case rates amongst children of different age groups, numbers of people under 18 who are hospitalized, and vaccination rates among kids over 12.
Kathy, do you want to go ahead?
Ian, there was a lot in there. So I will, we'll just take out a little bite at a time. So as far as case rates among children, I think what I can tell you is that we hit new records for the current outbreak in all age groups under 18 last week. So case rates are continuing to climb. I will point out that on the coronavirus.idaho.gov site under the schools tab, there's a dashboard link, and on that dashboard we are displaying case rates among school-age children 5 to 17. So that might be a good resource for you in the future. Those are updated weekly on Mondays. So that's the case rates. The next one was hospitalizations, I believe among children, so people less than 18, and those numbers can change day to day, but I can tell you for last week, what we saw is we're seeing about the same numbers we were seeing last December during our peak, during the last peak in the outbreak. There is a slight delay for cases that are hospitalized to be reported. So, you know, we have to look back a couple weeks before we call those numbers solid, but it looks like we're seeing just about the same as we were last peak. And then what was the other question?
About vaccination rates amongst kids who are eligible, if those are changing.
Yeah, I'm going to go ahead and turn it over to Sarah Leeds to give you the vaccination rates. Sarah?
Sarah, you're on mute if you're talking.
Thanks. I did not hear that question the first time around, so I'm looking it up right now. You're looking for vaccination rates for 12 and older? 12 to 15?
Yes.
While Sarah's looking for that, Ian, I do want to point out that those are available on our dashboard, the Tableau dashboard for all vaccine data. But I'll let Sarah pull up the latest and greatest.
Yeah, thanks. So as I'm looking at the dashboard, 12 to 15-year-olds who are fully vaccinated are, I'm sorry, 26%. And then 16 to 17-year-olds is 34% fully vaccinated.
Thank you.
All right, thank you, Sarah and Dr. Turner. Our last question of the day today is going to come from Melissa Davlin.
Thanks so much, Nikki. Dr. Souza, some of the misinformation that you were talking about is being spread by some pretty high-profile people in the state, including some elected officials and people who serve on public health boards. I was wondering if there has been any effort either by the hospital or perhaps the Department of Health and Welfare to reach out to some of the individuals who are spreading this misinformation and trying to meet with them or give them a tour of the hospital or anything to show them what's actually happening.
Yeah. Melissa, I'll start with that and then turn over to Dr. Souza for what the hospitals are doing. And if you don't mind, Dr. Souza, just at the top of this, you know, we continue to, try to, any of those rumors, things like that we hear about, misinformation, we are doing our level best to meet that where it is and provide the correct information and to dispel that misinformation. We're making our social media posts. We're doing these press briefings. That's one of the big major points of having these, and so we can provide that to the public. And certainly there are continual conversations that occur. There are regular conversations that occur with city officials, county officials, elected officials. legislators on a one-on-one basis, on group settings. And then I know that Dr. Souza has expressed to us, some of the actions that they've taken, which I think are also very impactful. And Dr. Souza, I'll turn it over to you.
Thanks, Elke. Well, yeah, in terms of direct outreach to those individuals, we're interested in talking with anyone at any time, but frankly, I think we're more interested in appealing directly to the public with factual information. Now we have done what we can, I think, to help key influencers to understand what's really happening. So, one of you on this call, Becky Boone, helped us with, thank you, Becky, an AP story that I think helped get the word out about the reality of what's happening. And that's really a direct appeal to the people and to the people who can influence the people. We have offered a limited number of, essentially visibility events to some in-state leadership to make sure, again, that they see with their own eyes and then can tell with their own voices what they saw. So we've made those efforts, but I think, I think accountability for folks who spread information, the wheels of accountability move slowly. I'm confident one day that accountability finds its home. In the meantime, trying to help people, save people, preserve hospital capacity for care, I'll continue to make direct appeals to the public and to the people who can influence the public. Thanks.
Thanks, Dr. Souza. All right, I think that is the last question of the day, so we'll go ahead and wrap it up. We are planning another media briefing next week on Tuesday at 2:30 in the afternoon. That's Mountain Time. Thank you all for your time this afternoon.